So good morning, good afternoon. As many of you know, I work as a field compliance officer with the Ohio Peace Officer Training Commission, which is a section within the Ohio Attorney General's office. And in that role, I monitor and evaluate and enforce law enforcement training for officers throughout the state of Ohio. So some of you may have wondered or are still wondering why someone who works in law enforcement has been part of a health equity fellowship. And there's been no one that has asked me that more than my colleagues back home. And they'd say, health equity? What in the world does that have to do with law enforcement? And in my explanation, I tell them how mental health wellness for law enforcement officers is so important, and that as of this morning, there have been 212 police officers who have died by suicide in the United States this year. That's an increase of over 40 from last year's numbers. I tell them how suicide is the second leading cause of death for individuals between the ages of 10 and 34 in the United States, and the 10th leading cause of death in the United States overall. I tell them that suicide is a global problem, with the World Health Organization estimating over 800,000 people dying by suicide worldwide every year. Suicide occurs across all demographics in all nations, affects all genders, ethnicities, and socioeconomic status. And every time I tell them this, I remember what I learned on the first week of our convening in January, and that is that I focus a little too heavy on stats all the time. I have also learned over the past year that sharing narratives is oftentimes an excellent way to motivate others and allow them to connect and understand your movement. So in preparing for this talk today, I thought about what brought me to this space, and that's really what my colleagues back home are asking me when they ask about the fellowship. What interests me in health equity? I have been witnessing health inequities before I even had heard of the term health equity. And while I may not have heard of the term, I certainly knew that there were large segments of the population experiencing health inequities daily. My first real job after grad school was when I was hired as a case manager for a local nonprofit in Cleveland, Ohio. This nonprofit specialized in forensic mental health care, specifically treating individuals who had severe mental illness and involvement within the criminal justice system. When I was shown to my office on my first day of work, there were 3 huge stacks of files on my desk, and the coworker who was showing me around said, "You can review those today, and then you can start making appointments with your clients tomorrow." And I said, "Appointments? What in the world am I meeting with these people about?" And she said, "Well, you have to meet with them once a week, and you can really meet with them for whatever you want to talk about. Ask them about probation, ask them about work, ask them about home. If they're taking their medications, are they using drugs, are they going to group? You'll probably have to help them with their SSI appeals and do group home applications with them with the county." And coming directly out of grad school, I really didn't have the foggiest idea what she was talking about with any of this. So I asked what I probably should have asked during my interview. I said, "Well, what kind of training am I going to get to do this?" And she laughed pretty hysterically, and she said, "Well, you don't get training here. You just figure it out. Like, we'll be around to help you. It's okay. You'll figure it out. It's no big deal." And off she went. And this is an inequity that is still pervasive in many community mental health systems today. There is minimal training and support for caseworkers, yet staff are expected to effectively deal and treat a wide variety of clients in a wide variety of situations. But as my coworker predicted, I eventually figured it out, and I also figured out that many of these clients were facing injustices daily. In the county I worked, anytime an individual was arrested and remanded to the county jail, they were required to see the court psychiatrist if they were presenting symptoms of mental illness at the time they were booked into the jail. Unfortunately, booking officers were not trained at all in mental health, so oftentimes symptoms went overlooked. For those individuals that advised the officer they were taking medications, they were put on a waiting list to see the court psychiatrist. Outside medications, prescriptions, and scripts were not accepted, so a mentally ill individual was taken off their medication upon being arrested and remanded to the jail, until they were seen by the court psychiatrist, which often took several weeks. Medications that they were then prescribed by the court psychiatrist were often entirely different than what they had been prescribed in the community. When an individual was placed on the mental health court docket, they were required to have an intake assessment, and the waiting list for this appointment was also often several weeks. Many would-be clients would languish in the county jail for no other reason than having to wait for an intake assessment. People's health and well-being was adversely affected by poorly constructed policies and bureaucratic red tape. Of course, there were success stories throughout my time there, but there were more frustrations than triumphs. Take, for example, one client who affectionately named herself Big Baby. And this was a very fitting name for her because she was about 6'4" and weighed 400 pounds. And despite her intimidating stature, she was the funniest and friendliest and most outgoing client I had. She was always laughing or always telling a joke. And like the other clients I worked with, she was battling mental illness, and her mental illness in some way had contributed to her past criminal activity. All of her offenses were low level and nonviolent, mostly drug-related offenses. And although she was only in her early 20s, she had a significant criminal involvement with the criminal justice system, as she had been within the court system since she was a young teenager. Coupled with her mental illness, she also had severe physical health limitations, so much so that the group home that she had been placed in declared that they could no longer care for her, and without any family to speak of at all, or other group homes available, she was court-ordered into a city nursing home. The first and last time I visited her at the nursing home, it was absolutely horrifying. This was no place I would want a loved one of mine, let alone my worst enemy. And walking in, I was immediately hit with the sour stench of urine, ammonia, and stale cigarettes. The reception area was dimly lit, and there were multiple light fixtures that were missing light bulbs. The employee at the reception station barely looked up from her magazine when I announced who I was and who I was there to see. She simply pointed over to the elevators and asked me to go up to the 3rd floor. The elevator opened to an even darker area. The overhead lights were flickering. There were cobwebs hanging from the ceiling. Various sounds spilled out into the hallway. Some people were laughing. I heard televisions, music. Some people were arguing. Some people were crying. It was like walking into a Halloween haunted house. When I finally found the room I was looking for, the usual happy-go-lucky Big Baby was anything but happy that day. I found her staring out her window. Her view was of an abandoned old factory, and she asked me, "When can I get out of here?" After a while, she told me, well, if I violate my probation, they'll definitely let me out of here. And knowing her history of low-level offenses, I told her they wouldn't. She'd simply have a court hearing, she'd likely get her probation extended, and she'd have more conditions and more requirements that she'd have to complete. I acknowledged that the facility was awful and that I was doing my best to find another placement for her, but encouraged her to stick it out and that I'd get her out of there as soon as possible. She agreed, but Big Baby was no stranger to the criminal justice system, and she knew exactly what she had to do to get out of the nursing home. The next morning, I arrived to find an arrest report on my desk at work. Big Baby had assaulted a nurse, her first and only violent offense in her history, and she was eventually sentenced to prison on that offense, an offense she deliberately committed so that she would not have to live in a nursing home with horrible conditions. Frustrations like these built. I felt a mixture of helplessness and discouragement, but I was also hesitant to leave because I felt a sense of responsibility for my clients, and I wanted to help them as best I could. Eventually, everything came to a screeching halt for me. It was Memorial Day weekend of 2007, specifically Sunday, May 27th. On that morning, I learned through a television news report that a client I had recently closed from services had been arrested and was being held in a local jail. He had been successfully terminated from probation a few months prior, and he had really been the poster child of compliance up until that point. He was attending all of his appointments on time and as scheduled. He was taking all his medication. He had secured employment, was attending group, and was even able to be living in independent housing. Once he was terminated from probation, he was no longer court-ordered or required to receive mental health services, and he decided that he no longer wanted to receive these services. He stated that the psychiatrist's office was too far from his home, and it took too many bus trips for him to get there. At that point, we suggested getting him linked with an agency closer to his home, but this would entail having another intake assessment and, again, being put on a waiting list. Although we could keep seeing him, he started missing his appointments more and more regularly. After numerous attempts to try to reach him by phone and in person, I was required, per my agency policy, to close him out of services. I had only caught his name on TV before they broke for a commercial break, but when the news returned, images of ambulances, police cars, and stone-faced police officers filled my screen. My former client had shot and killed a police officer, a 7-year veteran of a local police department where my uncle had worked, and I had several friends working as well. I remember standing in my living room that morning, feeling like the entire room was spinning around me. The news was shocking enough that a former client of mine had allegedly killed another person. But coming from a law enforcement family, the news that he had allegedly killed a police officer hit extra close to home. Officer down is something that shakes the entire law enforcement community to its core. The officer had been responding to a disturbance call due to noise from a large party. My client wasn't even at this party. In fact, the officer hadn't even approached or engaged with my client at the time. The officer likely didn't even see him at all. The officer had been immediately shot upon exiting his cruiser. His service weapon was still in its holster when the medics arrived. The fallout from this event took its toll on me. Over and over again, I thought about how the event could have been prevented, how I, perhaps, could have prevented it. Everyone told me there was nothing that I could have done, but I was more disenchanted with the community mental health system than ever. The entire system was broken, with no fix in sight, and perhaps cowardly, I left for a new job. I suppose I could have stayed and tried to work on changing the system, but at the time I didn't feel as though I had the tools or the mechanisms to do so. I began working as a probation officer, first with juveniles, and then first with adults and then with juveniles. For some reason, I thought that working in the court system, I would get away from the inequities I was seeing on a daily basis with community mental health. But they were there, perhaps more subtly, but they were there nevertheless. The criminal justice system itself is an interesting space. While we certainly need it, society needs rule of law, laws themselves are often enforced differently, as evidenced by the vast differences in incarceration rates among white and black males in the United States. While equal enforcement is certainly an issue, the injustices don't end there, as courtroom decisions are often anything but consistent, often ruling more favorably for certain variables, specifically whites, females, and those with a higher socioeconomic status. After working as a probation officer for several years, I transitioned into the role I have now. I have always been passionate about training, particularly appropriate and effective training, and monitoring and enforcing training was something I could enthusiastically get behind. I had seen firsthand what ineffective or outdated training could do, from the enforcement level and community interaction all the way to personal safety and tactical training. But back to my original question, what brought me to this space now? Law enforcement officers aren't traditionally seen as a marginalized population, but studies have shown that officers have some of the highest rates of non-communicable diseases than any profession. We train our police officers for physical encounters, we train on tactics and self-defense, and we train officers how to recognize and respond to mental health emergencies in citizens. But we do little to no training on mental health wellness for officers. Outside of the police academy, we rarely require additional physical training at all, let alone mental health training. The need for mental health wellness training in law enforcement should be a priority for every law enforcement agency across the globe. A simple Google search will show you that the suicide rates and depression rates among law enforcement officers is not singular to the United States. This is happening everywhere across the world. If officers fail to take care of themselves, both physically and emotionally, they will ultimately not be able to provide quality care to the citizens who rely on it in their own times of crisis. Failing to provide quality care can result in an us versus them mentality for both law enforcement and citizens alike. For a variety of reasons, mental health wellness training is not as accessible to law enforcement officers as it should be. And until it is, and stigmas are diminished, the stress of the job will continue to negatively impact officers and communities. Many of you know I coach high school cross country, which seems like it's off topic, but it's not, I promise. My runners love posting quotes all over our training room, and every year a favorite quote is one by Steve Prefontaine, which some of you may know. And the quote is, "To give anything less than your best is to sacrifice the gift." And while Pre was talking about his running ability, it certainly is applicable to all of us in this room as well. Over the past year, we have all grown together, spending every other Tuesday learning about equity in a variety of fields. We have learned about leadership tactics, principles, and techniques. We have learned about the power and value of community, as evidenced by our visit to Rwanda. We have learned about each other, not only about equity, but about our cultures, our families, our dreams and aspirations, and story of hope and encouragement, as we spend our time together. And as we wrap up this part of our journey, we are expected to be leaders for health equity. And this responsibility is not only in our professions, but in our day-to-day. As leaders for health equity, we must not sacrifice the many gifts we have been fortunate enough to experience over this past year. Moving forward, we must always give our best so that we can be warriors for health equity for all. Thank you.